Welcome to our presentation on evaluating CPHE. Community Partners for Health Equity, also known as CPHE, is a program of the Medical Education Cooperation with Cuba, also known as MEDIC. CPHE has three components: CPHE 1.0, 2.0, and CPHE Network. In 1.0, participants work with MEDIC staff to select the Cuban health models and practices that are most relevant to their community's needs. In 2.0, CPHE provides funds for select CPHE 1.0 sites to explore, plan, and pilot a health model based on what their leaders learned in Cuba. All participants in 1.0 are invited to participate in the CPHE network before, during, and after their visits to Cuba. As CPHE network members and participants, they can share their experience through listservs, webinars, and an annual meeting. In our evaluation, we recommend evaluating 4 new sites with about 80 participants. Demographic and background data is still to be determined, but we do know that CPHE serves United States vulnerable communities.
The CPHE program is really about using Cuban health practices to advance health equity in underserved communities in the United States by fostering transformative learning or transformative change of CPHE participants. Therefore, our evaluation questions center on these two goals. Our primary evaluation questions include: does participation in CPHE help individuals and home organizations address health equity? And then how does CPHE help these individuals and organizations address health equity? We also have secondary evaluation questions including: does CPHE foster transformative change at the individual level? And what are the indicators of transformative change in both individuals and organizations? To date, there have been no published evaluations of the effectiveness of CPHE in promoting transformative change or advancing health equity. However, in 2017, CPHE had begun to plan an evaluation of the program. There have been similar evaluation programs at the individual and organizational levels. The individual level programs have mostly highlighted the importance of experiential or situational learning in promoting change. For example, a fellowship program in Africa where health professionals were placed at health agencies found improvements in fellows' ability to gain promotions, improve job performance, and increase networking. At the organizational level, Kovan and Dirks found that organizational change occurred when workers recognized and understood their work as a calling. In addition, this study found that for true organizational change to occur, the whole organization needed to be invested. Overall, for both individual and organizational change, the primary finding was that transformative change does not occur after a single session. Instead, it is an ongoing and continuous process.
In designing this evaluation, we laid out the relationship between the inputs, activities, participation, and outcomes of the program in this simplified logic model. Some of the key inputs are staff time, on behalf of MEDIC to identify candidates for the CPHE program, on behalf of participants to select relevant models and travel to Cuba, and on behalf of Cuban health staff to facilitate the visits. Important activities include providing technical assistance to participants, training participants about the Cuban health system, and planning the trips to Cuba. The short-term outcomes that we identified were increased knowledge about how to advance health equity in vulnerable U.S. communities, transformative change in attitude toward addressing health equity, and increased community engagement skills. In the long term, the CPHE program aims to see an increase in the number of policies, programs, initiatives, advocacy, or actions at the organizational and community level to advance health equity. As our prior research identified very little relevant literature about transformative change in this context, we developed our own indicators. Some indicators aim to measure changes in attitudes, skills, or knowledge. For example, we are measuring changes in knowledge about health equity, barriers to health equity, and Cuban health models to address health equity. We are also interested in understanding if participants are more prepared to identify and address systemic disparities in health and social determinants of health. Other indicators aim to measure more long-term outcomes. At the organizational level, we are interested in looking at the number of organizational policies adopted to address health equity. From our review of past program materials, we think an example of this could include changes within the healthcare system to improve care coordination or information exchange. At the community level, we are interested in looking at the number of implemented practices, policies, initiatives, or programs intended to address health equity. Previous examples have included a tenant rights program and healthy food initiatives. To evaluate the CPHE 1.0 program, we are using a mixed methods evaluation design. The quantitative methods will include two types of pre-post questionnaires. The first will assess organizational and external actions taken to address health equity. The second will look to assess certain aspects of transformational change at the individual level. The qualitative methods will include focus groups, key informant interviews, and a content analysis. We will hold focus groups before and after the trip to Cuba, and Robin will review some of our framing questions on the next slide. We will also conduct key informant interviews with implementers in Cuba, MEDIC leadership, and past participants in CPHE 1.0. These will provide important contextual information about which pieces of the program are key to transforming participants' views towards health equity, and how participants have been able to apply lessons learned in their communities. Finally, the content analysis will involve a review of past program materials, and this analysis will help to identify historical markers of transformative change, and that could include evolving definitions of health equity.
The complexity of our evaluation plan will require the collection of both quantitative and qualitative data. As Lucy described, we have 3 different indicators and 5 different methods for capturing information. We will collect quantitative data about organizations and individuals' knowledge, skills, and experience with advancing health equity in their communities through pre- and post questionnaires. Participants will read a statement and then respond by selecting a Likert scale answer ranging from strongly disagree to strongly agree. Questionnaires will include statements such as, "There are systematic disparities in health between groups in my community," and "I am able to identify health disparities in my community." We will also collect qualitative data. These data will come from focus groups, key informant interviews, and the content analysis. In these data, we're interested in learning about the participants' conceptions of health equity, motivations to address health equity, and capacity to affect change. We will also hope to collect descriptions of specific pieces of the program that are identifiable as transformative for participants. Our data will come from a sample of 80 CPHE participants. We plan to select new CPHE sites as they are identified and recruited by MEDIC. We anticipate that over 2 years, 4 sites could participate in the evaluation with an average of 20 people per site, or a total of 80 participants. Since we have relatively small sample sizes, we will attempt to recruit all 80 CPHE 1.0 participants for the evaluation in order to maximize the quality of our data and our ability to report reliable conclusions. The evaluation timeline for this project will be 12 months, beginning in January 2018 and ending in June 2019. As you can see in this visual description of our timeline, there are many overlapping activities. We'll begin our evaluation with some planning, which will include preparing the evaluation and piloting our evaluation tools. At the same time, we'll train staff to administer data collection tools and complete the content analysis. We hope the content analysis will provide information that will help us craft better questions for focus groups and key informant interviews. We included the trip to Cuba in our timeline because it shows how we will complete pre- and post surveys and focus groups around the trip. We anticipate that focus groups and key informant interviews will take a while to complete, which is why they have longer timelines than other activities. After data collection is complete, we'll begin data cleaning and analysis, where we'll go through the data from the key informant interviews, surveys, and focus groups. Last of all, we will prepare a written report and a presentation for CPHE stakeholders. These presentations and final information sharing activities will include a discussion of next steps for how to usefully incorporate what CPHE staff have learned from the evaluation. To close, we want to show this quotation from CPHE participant Cynthia Davis. Cynthia's words suggest that she had a powerful experience in CPHE and that MEDIC, CPHE's parent program, is doing transformative work. The purpose of this evaluation plan was to design a way to draw concrete examples from statements like Cynthia's. Participants and staff of CPHE are confident that this program is making a difference, but they need evidence to back up these statements. Although we do not know what the evaluation of CPHE 1.0 will find, we have done our best to design a comprehensive, mixed methods, non-experimental evaluation of the program in hopes of identifying this evidence. The 4 of us enjoyed putting our new evaluation knowledge to work on this project, learning about community partners for health equity, and researching the complex area of transformative change. We wish to thank Dr. Meredith Minkler of UC Berkeley and Diane Applebaum of MEDIC for the information they shared to make this project possible. Thank you also to Dr. Mara Decker, Lisa Unti, and Bridget Kakuros for their excellent instruction.